So let us now understand the normal functioning of the CFTR channel. Now, very importantly, as we see over here that this is the epithelial cell, okay, this is the cell membrane of the epithelial cell over here. So whatever we are seeing, this is the plasma membrane of the epithelial cell, and what we can appreciate over here is a normal CFTR anion channel. Now, a normal CFTR anion channel is comprising of two transmembrane domains. So you can appreciate over here in pink that there are two transmembrane domain over here. Along with that, there are two NBD domain. NBD stands for nucleotide binding domain, and there is a single R or regulatory domain. So these are all the domains which are components of the normal CFTR anion channel. So I repeat that there are two transmembrane domain, there are two NBD domain, and there is a single regulatory domain. Now, from this particular diagram, if you can appreciate that the two transmembrane domain that we can appreciate over here, this and this transmembrane domain, they are basically forming a channel for the secretion of ions, mainly the chloride ion channel secretion. So they are basically forming a channel which is going to facilitate the secretion of this particular chloride ion. Now, very importantly, there are two NBD domains as we can appreciate. Now, the role of this NBD domain is to provide the site for ATP hydrolysis. Okay, it provides the site for ATP attachment and hydrolysis of the ATP, and this is very important for activation of this CFTR channel. Now, without the ATP binding and hydrolysis, this channel cannot be activated. So for the activation of this CFTR channel, this ATP binding and ATP hydrolysis is very important, and this is facilitated by phosphorylation which is taking place at the regulatory domain. So how does this phosphorylation occurs? Now, very importantly, as you can appreciate that there is an agonist, acetylcholine, for example, okay, they are going to enter the epithelial cell, okay, and they are going to increase the amount of CAM, that is called as cyclic adenosine monophosphate level. So they will increase the level of CAM, and this CAM is going to activate the protein kinase A, which is going to facilitate the phosphorylation of the regulatory domain in presence of the ATP. Once there is phosphorylation of the regulatory domain, they are going to stimulate the ATP binding at the NBD site. So there will be ATP binding and hydrolysis, and that is going to activate the CFTR channel, okay, that we can appreciate over here, which is formed by the two transmembrane domain. So this is the normal functioning of the CFTR, and at the end there is secretion of the chloride ions. Okay. Myself, Dr. JIBRAN Ahmed, presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to understand about cystic fibrosis in detail. It is one of the very important inborn errors of metabolism, and very importantly, now it is being increasingly asked in your exams, not only as a long answer question but also as a short answer question, and multiple MCQs are also asked. Why this topic is very important? Because conceptually this is little bit difficult to understand, and today I am going to clear each and every doubt related with this particular topic. So let us begin this topic without wasting any time. So cystic fibrosis, it is an inherited disorder of iron transport that is affecting fluid secretion in the exocrine glands and in the epithelial lining of the respiratory tract, gastrointestinal tract, reproductive tracts. Classically, this disorder is characterized by the formation of abnormal viscous secretion, which is responsible for the classical clinical features of this disease, characterized by chronic lung disease because of recurrent infections, pancreatic insufficiency, steatorrhea, malnutrition, hepatic cirrhosis, intestinal obstruction, and male infertility. Now, the manifestations, they appear at any point in life, starting from birth to childhood to adolescence. Now, now remember that cystic fibrosis, it is the most common lethal genetic disease affecting Caucasian population. It is an autosomal recessive disorder, but although it is a Mendelian disorder, and although it is autosomal recessive, some of the heterozygotes carrying the CFTR mutation in one of the alleles, they also manifest the disease. So they do not follow the Mendelian pattern of inheritance completely. Okay, so I will just repeat once more that it is an autosomal recessive disorder. Any autosomal recessive disorder is manifesting only in the homozygous state, but cystic fibrosis is one such autosomal recessive disorder that is manifesting even in the heterozygote state. And not only that, they are having a wide degree of phenotypic variations. And this wide degree of phenotypic variations occur because of diverse mutations, because of tissue specific effects and influence of modifier genes. Okay, so what do you mean by wide degree of phenotypic variation? That means the clinical features, they vary. Okay, they can have a lot of variations in the clinical features. And such variations in their clinical features occurs because there is a diverse set of mutations which is causing cystic fibrosis, and there are certain mutations which is affecting certain tissues. So certain tissue specific effects are there, and there is influence of certain modifier genes which is also altering the course of the disease. So we will understand in details about each of them in the later half of the video. So stay tuned till the end of the lecture. Now, before we understand about the cystic fibrosis, we have to understand the normal function and structure of the cystic fibrosis gene. So, the primary defect in cystic fibrosis is abnormality of transport of the chloride and bicarbonate ions, which is normally mediated by an anion channel, which is called as the CFTR channel. Okay, so the CFTR channel is basically, defect. Okay, and this is encoded by the CFTR gene which is present on chromosome number 7q. Okay, so very importantly, I will repeat once again, the primary defect in cystic fibrosis is abnormality of transport of chloride and bicarbonate ions, which is mediated by an anion channel called as the CFTR channel, which is encoded by CFTR gene which is present in the chromosome number 7q. Now, the full form of CFTR, it stands for Cystic Fibrosis Transmembrane Conductance Regulator. So, let us now understand the normal functioning of the CFTR channel. Now, very importantly, as we see over here that this is the epithelial cell. Okay, this is the cell membrane of the epithelial cell over here. So, whatever we are seeing, this is the plasma membrane of the epithelial cell, and what we can appreciate over here is a normal CFTR anion channel. Now, a normal CFTR anion channel is comprising of two transmembrane domains. So, you can appreciate over here in pink that there are two transmembrane domain over here. Along with that, there are two NBD domain. NBD stands for nucleotide binding domain, and there is a single R or regulatory domain. So, these are all the domains which are components of the normal CFTR anion channel. So, I repeat that there are two transmembrane domain, there are two NBD domain, and there is a single regulatory domain. Now, from this particular diagram, if you can appreciate that the two transmembrane domain that we can appreciate over here, this and this transmembrane domain, they are basically forming a channel for the secretion of ions, mainly the chloride ion channel secretion. So, they are basically forming a channel which is going to facilitate the secretion of this particular chloride ion. Now, very importantly, there are two NBD domains as we can appreciate. Now, the role of this NBD domain is to provide the site for ATP hydrolysis. Okay, it provides the site for ATP attachment and hydrolysis of the ATP. And this is very important for activation of this CFTR channel. Now, without the ATP binding and hydrolysis, this channel cannot be activated. So, for the activation of this CFTR channel, this ATP binding and ATP hydrolysis is very important. And this is facilitated by phosphorylation, which is taking place at the regulatory domain. So, how does this phosphorylation occurs? Now, very importantly, as you can appreciate that there is an agonist acetylcholine, for example, okay, they are going to enter the epithelial cell, okay, and they are going to increase the amount of CAM, that is called as cyclic adenosine monophosphate level. So, they will increase the level of CAM. And this CAM is going to activate the protein kinase A, which is going to facilitate the phosphorylation of the regulatory domain in presence of the ATP. Once there is phosphorylation of the regulatory domain, they are going to stimulate the ATP binding at the NBD site. So, there will be ATP binding and hydrolysis, and that is going to activate the CFTR channel, okay, that we can appreciate over here, which is formed by the two transmembrane domain. So, this is the normal functioning of the CFTR, and at the end, there is secretion of the chloride ions, okay. So, let us see over here. So, each CFTR gene, as we can appreciate, each CFTR channel is comprising of two transmembrane domain, which is forming a channel for the passage of the chloride ions, as we can appreciate over here. Okay, so they are forming a channel for the passage of the chloride ions. Now there are two NBD domains. As I told you, they are called as the nucleotide binding domain. Okay, now very importantly, the ATP binding and hydrolysis is occurring at this NBD site, and this is very essential for the opening and closing of the channel pore, which is enhanced by the presence of the phosphorylated regulatory domain. So remember that ATP binding and hydrolysis at the NBD domain is essential for activation of the CFTR anion channel and subsequent chloride secretion. And lastly, we are having the regulatory R domain, which is having the phosphorylation site. Now, whenever the agonist is, whenever there is agonist induced increase in the level of CAMP, they are going to activate the protein kinase A, which is going to carry out the phosphorylation of the regulatory domain. And the phosphorylation of the regulatory domain is facilitating the ATP binding and hydrolysis at the NBD domain, which itself is activating the CFTR channel and causing chloride secretion. So if we are going to summarize, when the agonist binds to the epithelial cells, okay, they are increasing the level of CAMP within the epithelial cells, which is in turn is going to activate the protein kinase A, which in turn is going to facilitate the phosphorylation of the regulatory domain. That is going to increase the ATP binding at the nucleotide binding domain side, which in turn is going to activate the CFTR chloride anion channel, leading to its opening and chloride secretion. So this is the normal functioning of the CFTR anion channel. Okay. Now we are going to understand the etiopathogenesis of cystic fibrosis, and the only way to understand is that there are certain, certain facets, very important facets of CFTR function. Let us try and understand, and understanding of this part is very important for understanding the etiopathogenesis of cystic fibrosis. So let us start. So CFTR, as we have seen, that predominantly they are regulating the secretion of chloride, but it is not the only ion, okay, which is regulated by CFTR. So CFTR regulates multiple ion channels and cellular process. So in addition to the chloride conductance channel, CFTR, they can regulate additional ion channels and cellular process. So what are the other ion channels which are regulated by the CFTR? They are the potassium channels, that is the Kerr 6.1, epithelial sodium channels and gap junction channels. So out of these three, which is also regulated by the CFTR, the regulation of epithelial sodium channel is very, very important. Okay. Now CFTR is working very closely with the epithelial sodium channel. Now this epithelial sodium channel, normally they are also situated on the apical surface of the epithelial cells, and it is normally responsible for the reabsorption of sodium from the luminal fluid, rendering the luminal fluid hypotonic. So let me just explain you. So for example, there are the epithelial cells over here. Okay, very, very importantly. Okay, these are the epithelial cells over here. Now very importantly, these epithelial cells, they are having certain epithelial sodium channel. Now the function of this epithelial sodium channel, normally it is to cause reabsorption of sodium from this luminal fluid. Okay. So what is going to happen if excess amount of sodium will be reabsorbed? So along with that, water will be reabsorbed as well. So as a result, the lumen is going to become hypotonic. They are going to become hypotonic. This is the normal functioning. So this epithelial sodium channel is normally inhibited by the normally functioning CFTR gene or the normally functioning CFTR channel. But in case of cystic fibrosis, remember one thing. Okay. In cystic fibrosis, because there is mutation in the CFTR, so CFTR is not being able to function. So as a result, there will not be inhibition of epithelial sodium channel, and therefore the epithelial sodium channel activity is going to increase, which is going to increase the sodium uptake across the apical membrane. So there will be excessive amount of sodium reabsorption across the apical membrane. Now at all places of the body, that is wherever there is an epithelial lining, be it the gastrointestinal tract or be it your GI tract or the respiratory tract, in all these places this is happening in cystic fibrosis. There is excessive amount of epithelial sodium channel activity with increased sodium uptake across the apical membrane. This is what is happening normally at all places except the sweat duct. In the sweat duct, okay, in the sweat duct, in case of cystic fibrosis, the epithelial sodium channel activity is increasing. Okay, so epithelial sodium channel activity, remember, it is increasing at all the places in case of cystic fibrosis except the human sweat duct, wherein in the human sweat duct the epithelial sodium channel activity is reducing. So whether you look at the gastrointestinal tract, whether you look at the respiratory tract, at all places the epithelial sodium channel activity is going to increase in cystic fibrosis except the sweat ducts, wherein the epithelial sodium channel activity is going to decrease, and as a result there will be decreased sodium uptake from the luminal fluid, and as a result the luminal fluid will become hypertonic with high amount of sodium chloride. This is leading to salty sweat, okay, which is often detected by the mothers. Okay, so we will appreciate salty sweat in affected infants. Okay, so very importantly, I will repeat once again that our normal CFTR is not only regulating the secretion of chloride ions, but they are also regulating the secretion of multiple other ions, like for example potassium channels are there, epithelial sodium channels are there, gap junctions are there. So out of these other channels which are regulated by CFTR, they are working very closely with the epithelial sodium channel. Now a normally functioning epithelial sodium channel is normally inhibited by the normally functioning CFTR ion channel. Now in conditions where the CFTR ion channel is becoming deactivated or mutated, for example in case of cystic fibrosis. So what is going to happen in cystic fibrosis? There is mutation of the CFTR, so we do not have a normally functioning CFTR. As a result the epithelial sodium channel will not be inhibited, so there will be excessive amount of epithelial sodium channel activity in all places of the body, that is in the respiratory tract, in the GI tract. The epithelial sodium channel activity is going to increase, so the sodium reabsorption will increase in these places, except in the sweat duct. In case of cystic fibrosis, in the sweat duct, okay, there is opposite activity. There is decreased epithelial sodium channel activity, and as a result there is a decreased sodium uptake from the luminal fluid, leading to hypertonic luminal fluid with high amount of sodium chloride concentration, causing salty sweat. Okay, so in cystic fibrosis, classically you have a very salty sweat, and that is usually detected by the mothers of the affected infants. So let us try and understand the etiopathogenesis. So as I already explained to you people, very importantly, if we see over here, so normally the CFTR, normally they are inhibiting the epithelial sodium channel. Okay, so therefore they are decreasing the sodium absorption normally, but the inhibition is not that much. There is normal amount of inhibition of epithelial sodium channel. But in case of cystic fibrosis, where there is a mutated CFTR, so at all places of the human body, including the gastrointestinal tract, including the respiratory tract, okay, what is going to happen? Because the CFTR is not functioning, so there will be excessive amount of epithelial sodium channel activity, and as a result there will be an increased amount of sodium absorption. So epithelial sodium activity will increase at all places of the body. Whereas in case of the sweat duct, okay, the epithelial channel activity decreases, okay, and it decreases as compared to the normal. Normally also they are inhibiting, but in case of cystic fibrosis at the sweat duct, the activity of the epithelial sodium channel is reduced drastically. So there is a very highly reduced amount of sodium reabsorption, and as a result whatever luminal fluid is there or whatever sweat that is remaining, they are having an increased amount of sodium and chloride, as the sodium over here they are not reabsorbed. As a result, thus the luminal fluid becomes hypertonic, responsible for the salty sweat that we are seeing in case of cystic fibrosis. Now, the second important facet of cystic fibrosis in the etiopathogenesis is that the function of the CFTR, they are tissue specific. Therefore, the impact of the mutation in CFTR is also tissue specific in nature. If we see over here, the normal CFTR anion channels, if we can appreciate, so normal CFTR anion channel at the level of the sweat gland and at the level of the respiratory or intestinal epithelium. So we are going to see the normal functioning of the CFTR channel in the sweat gland versus the respiratory or the intestinal epithelium. So normally at the level of the sweat gland, okay, the CFTR channel, they are facilitating the reabsorption of chloride via the CFTR channel. So this is the basic epithelial lining of the sweat ducts. These are the epithelial cells, and you can appreciate there is a characteristic CFTR channel which is causing the chloride ion reabsorption. So normally at the level of the sweat duct, okay, the normal CFTR is facilitating the reabsorption of the chloride via the CFTR gene, and they are also stimulating the epithelial sodium channel to cause reabsorption of sodium channel. So this is basically the lumen. So lumen of a normal sweat duct is always containing hypotonic fluid, because the normally functioning sweat ducts or the normally functioning CFTR is facilitating both sodium as well as chloride reabsorption. Okay, so this is the case in the sweat gland, normal sweat gland. In case of a normally functioning CFTR at the level of the respiratory or intestinal epithelium, they cause active luminal secretion of chloride ions via CFTR. So for example, this is the epithelial lining of the respiratory or the intestinal epithelium, and this is the lumen. So what is happening, that the epithelial cells which are lining them, they are causing active secretion of the chloride ions. So there is an active secretion of chloride ions via the CFTR channel, and there is a normal sodium and water reabsorption which is taking place at the level of the respiratory epithelium or the gastrointestinal epithelium. So the sodium water reabsorption is taking place normally over here. So normal amounts of sodium and water are reabsorbed over here. Okay, this is the normal functioning. In case of cystic fibrosis, wherein we are having an abnormally functioning CFTR, so let us see what is the effect that we see at the level of the sweat glands. So whatever the normal functioning was there, that will be reversed. So now there is a decreased reabsorption of sodium and chloride. So this is the lumen over here, and this is the epithelial lining of the sweat duct that we can appreciate. So neither the chloride nor the sodium ions, they are not reabsorbed. So as a result, the lumen is containing excessive amount of sodium and chloride. So the lumen is containing excessive amount of sodium chloride, and as a result, the luminal fluid becomes hypertonic, responsible for the salty sweat that we appreciate in case of cystic fibrosis. So the luminal fluid in case of cystic fibrosis at the level of the sweat duct is hypertonic. Very, very important MCQ over here. So this is at the level of the sweat duct. But what happens at the level of the respiratory or the intestinal epithelium? We are going to appreciate over here that the normally what was happening, that there was a chloride secretion. So over here, because the CFTR channel is abnormal, there is loss or reduction of the chloride secretion. No more, the chloride cannot be secreted anymore into the lumen, number one. The number two thing is that normally, normal amounts of sodium and water were reabsorbed. But because of mutation in the CFTR, as a result, the epithelial sodium channel is functioning more. So there is an excessive activity of the epithelial sodium channel, and excessive amount of sodium and water is reabsorbed. As because the sodium is reabsorbed, they are osmotically active, so they are also going to take excessive amount of water with them. So in this case, in case of cystic fibrosis, if you are looking at the respiratory or the intestinal epithelium, the lumen is now containing no chloride, and it is also containing no sodium, and there is no water. So both chloride as well as sodium are reduced, but along with that the amount of water has also reduced, and which has led to the formation of a dehydrated mucus. Now because both the sodium as well as chloride levels becomes low, so as a result the luminal or surface fluid is isotonic, yet they are dehydrated. They are dehydrated. So the lumen contains mucus. So in the respiratory tract, in the intestinal epithelium, we are going to have a lumen which is filled with mucus that is dehydrated, yet they are isotonic because the amount of sodium and chloride is less, proportionately they are less. And this dehydration at the level of the respiratory or the intestinal epithelium leads to defective mucociliary clearance and accumulation of hyper-concentrated viscid secretions, which is going to obstruct the air passage, leading to recurrent pulmonary infections. So this is the second very important, etiopathogenesis factor of cystic fibrosis. Thirdly, CFTR is also regulating the transport of bicarbonate ions. Now the anion CFTR channel, it is not entirely specific for only chloride ion secretion. It is also permeable to bicarbonate ions. Now the anion CFTR channel has interaction with SLC26 family of anion exchanges as well. Now remember, normally the tissue secretes alkaline fluids. In cystic fibrosis, because there is a decreased secretion of bicarbonate as well, therefore the normal tissue secretions, they become acidic in nature. And this is going to reduce the pH of the luminal fluid, and that is further going to precipitate the mucin precipitation, as well as they are going to facilitate the plugging of the ducts and increased bacterial binding to the plugged mucin, thus facilitating excessive infections as well. Now, the pancreatic insufficiency in cystic fibrosis is virtually always present when there are CFTR mutations with abnormalities in bicarbonate ion conductance. Okay. So this is all about the etiopathogenesis of cystic fibrosis. I will just summarize. Whenever there is abnormality of the CFTR at the level of the sweat glands, remember there will be a decreased reabsorption of sodium and chloride. As a result, the luminal fluid will become hypertonic. So there will be a salty sweat, and this is a very important screening test which is detected by the mothers itself. Okay. In the respiratory or intestinal epithelium, as we know that the CFTR abnormality leads to excessive epithelial sodium channel activity and reduced chloride secretion into the lumen. So the lumen ultimately has reduced level of chloride, sodium as well as reduced level of water. Because of that, the luminal fluid, that is the mucus, becomes dehydrated, and that is leading to defective mucociliary secretion with a result of viscid secretion which is obstructing the air passage, leading to recurrent pulmonary infections. Not only that, they are also hindering, abnormal CFTR gene is also hindering the conductance of bicarbonate, and because normally the tissue fluid secretion, they are alkaline, in absence of bicarbonate secretion in cystic fibrosis, the luminal pH is falling down, which is further precipitating the mucin precipitation and plugging of the ducts with increased bacterial binding of the plugged mucins and excessive infections. Now, individuals who are having abnormal bicarbonate conductance, okay, in those individuals, virtually all such individuals, they present with pancreatic insufficiency. Okay. Now we are going to discuss the cystic fibrosis gene, the mutational spectrum and the different classes of mutations that we see in cystic fibrosis. So let us discuss this part in detail. Now, if you see over here that there are more than 2000 disease associated mutations have been identified, but only 5 mutations are having a relative frequency of 1% or more. So although so many mutations are there, there are only few mutations which are clinically relevant. Most of these mutations, they are missense mutations. Okay, this is the most common type of mutation that you will come across in case of cystic fibrosis, whereas the other types of mutations that we see are the frame shift mutation, the splicing mutations, then we are having the nonsense mutation. Okay. Now we have 6 classes of mutations can be seen in cystic fibrosis. The class 1 to 3 mutations, they are called severe mutations, and these mutations leads to less than 10% residual CFTR activity. Okay. Whereas the class 4 to 6 mutations, these are the milder mutations wherein we are having less than 20% residual CFTR activity. Okay. So let us now discuss the different classes of the CFTR mutation. So first, very importantly, we are having the class 1 CFTR mutation wherein there is a defect in the protein synthesis. Such mutations, they are also called as the null mutations. So over here, there is a complete lack of CFTR protein, and this occurs because of premature termination of protein translation. The second class, if you see, that is the class 2 mutation, is characterized by abnormal protein folding, abnormal protein processing or trafficking. Okay, so defective protein, now defective processing of the protein occurs while it is on its way from the endoplasmic reticulum to the Golgi apparatus. And because of this defective processing of the protein, there is abnormal protein folding and glycosylation. Therefore, this abnormally or misfolded proteins, they are finally degraded. So it is also the most common CFTR mutation. So the most common CFTR mutation, it is the class 2 mutation which occurs because of deletion of 3 nucleotides which is coding for phenylalanine at delta F508 position. It is present in 70% Caucasian cystic fibrosis patients, and there is near complete, not total lack, there is near complete lack of CFTR protein. There is no complete lack, but there is a near complete lack of CFTR protein. So very important MCQ over here is that the class 2 is basically there's a processing or trafficking or protein folding defect over here, and it is also the most common CFTR mutation that we see, and it is mainly occurring because of deletion of 3 nucleotides which are coding for phenylalanine at position 508. Now the class 3 mutations, if we are seeing, there is a defective regulation also called as gating mutation. The class 3 mutations are basically due to the defective regulation, and also called as the gating mutation. So there is a prevention of activation of CFTR by inhibiting the ATP binding and hydrolysis, an essential prerequisite for ion transport. So in the normal functioning of the CFTR, we had seen that for the normally activation of the CFTR, the ATP binding and hydrolysis at the NBD side is very important, and that does not take place. So over here there is prevention of activation because of inhibition of ATP binding and hydrolysis at the NBD side. So over here you find normal amounts of CFTR, but they are non-functional. The class 4 mutation, if we see, there is a decreased amount of conductance, so they are called as conduction mutation. So the mutation affects the transmembrane domain of the CFTR, which forms the ionic pore for the chloride transport. So that is why we have to understand the normal functioning of the CFTR. That is why I taught you that in details initially, so that you can understand the mutation spectrum easily. Okay, so over here again there is normal amounts of CFTR, but they are having reduced chloride conduction. At the class 5 mutation, there is a reduced abundance called as production mutation. So the mutation affects the intronic splice site or CFTR promoter. So there is a reduced amount of normal CFTR protein anion channel. Then we are having the class 6 mutation. There is a decreased membrane CFTR stability, also called as instability mutation. So there is fully processed and functional protein, but with greatly reduced membrane stability. So this is the mutational spectrum of cystic fibrosis. Now, having discussed in details about the mutation spectrum, now let us understand few important concepts. So what is the classic cystic fibrosis phenotype? If there is classic, there will be atypical, or there will be non-classic cystic fibrosis as well. So first we are going to understand about the classic variety of cystic fibrosis phenotype. So classically they present with a triad of pancreatic insufficiency, sinopulmonary infections, and gastrointestinal symptoms. Okay, so cystic fibrosis, as I told you, it is an autosomal recessive disorder. Therefore, affected individuals have mutations in both the alleles. Okay, but the nature of the mutation on each of the two alleles, they have remarkable effect on the clinical features or on the phenotype of the patient. If for example, this is the cystic fibrosis, okay, gene, and there are two alleles. Okay, now for example, if there are two severe mutations, if both the mutations which are affecting the gene, they are severe, like this. If two severe mutations are there, then that is going to lead to virtual absence of the membrane CFTR function, which is associated with the classic cystic fibrosis phenotype, which is characterized by pancreatic insufficiency, sinopulmonary infections, and GI symptoms. But sometimes what happens that certain milder mutations are present. So for example, if out of two mutations, one of them is mild, or for example, both of them are mild mutations. Okay, so that is going to result in a less severe phenotype. Now, there is also one important thing is genotype-phenotype correlation. Okay, so very important thing is that the genotype-phenotype correlation is most consistently seen for pancreatic disease. Okay, it is seen for pancreatic disease. Now, those individuals who are homozygous, or where both the alleles are involved, they will always involve the pancreas. Whereas whenever there is milder mutation with some amount of CFTR activity, then pancreatic insufficiency is not present, or pancreas is spared. So the genotype-phenotype correlation is most consistently present for pancreatic disease only. So this is the clinical feature for which if the genotypic mutations are severe, then the pancreatic disease is bound to occur. But if the mutations are mild, then it is going to prevent the pancreatic insufficiency. Now, what is non-classic or what is atypical cystic fibrosis? So few patients who are having biallelic CFTR mutations, they do not demonstrate all the clinical features of cystic fibrosis, or they have clinical features which are unrelated to cystic fibrosis. For example, patients with idiopathic chronic pancreatitis, or patients with late onset chronic pulmonary disease, or idiopathic bronchiectasis, or patients with obstructive azoospermia. Okay, so this is the non-classic or atypical cystic fibrosis. Now, if you remember, as I told you, that the phenotype of an individual or the clinical features of an individual with cystic fibrosis depends on certain genetic and environmental modifiers. So what are those genetic modifiers? So there are certain genes like the MBL2 gene, TGF-beta1 gene, interferon regulated developmental regulator 1 or IFRD1 gene. So polymorphism in any of these genes can regulate resistance of the lungs to exogenous infections, thus modifying the natural history of cystic fibrosis. Therefore, the pulmonary clinical features or the pulmonary manifestations of cystic fibrosis can be modified if there are any polymorphism in certain genes. So these genes which are affecting the pulmonary manifestation of cystic fibrosis, they are called as the genetic modifiers. Similarly, what are the environmental modifiers? Okay, so if for example a patient of cystic fibrosis is there, and if those patients are constantly they are affected by any kind of infection, then that can also change the course of the disease. Okay, so for example, Pseudomonas aeruginosa, they colonize the lower respiratory tract first, intermittently, then chronically. Now static mucus, because the mucus over there is static because of the defective mucociliary clearance, so the static mucus in cystic fibrosis creates a hypoxic environment in the airway surface fluid. So this favors the production of a biofilm that is called as alginate, and this alginate, it is permitting the formation of biofilm on the surface of the bacteria Pseudomonas, which is providing a protection to the bacteria from the antibodies as well as from the antibiotics. Therefore, they evade the host defense and therefore they cause chronic destructive lung disease. Why there is chronic destructive? Because of the infection by the organisms and because of the formation of the biofilm. So the body cannot act against them, the antibodies cannot act against them, and the antibiotics are also not effective against them. So as a result, they are staying inside the body, and they are they are stimulating inflammatory reactions, which ultimately is causing chronic destructive lung disease. So antibodies and cell-mediated immunity induced by the bacteria, they are causing further pulmonary destruction. So why this kind of destruction is happening? It is happening because of the infection by the Pseudomonas aeruginosa, which is basically changing the course of the disease completely. Okay, approximately 80% of the patients of cystic fibrosis are colonized by Pseudomonas aeruginosa by 20 years of age, and this modifies the severity and progression of the lung disease in cystic fibrosis. It makes the disease worse. So this is the environmental modifier in case of cystic fibrosis. So having discussed the etiopathogenesis of cystic fibrosis in details, now we are going to discuss the morphology of the cystic fibrosis. So the basic thing is that, as I told you, that there is a basic problem and there is the basic clinical features are associated with all the exocrine glands of the body. So basically what happens, I will just show you any kind of exocrine gland. Okay, this is an exocrine gland. Any kind of exocrine gland, they are having certain epithelial cell lining, and there they are having certain secretions, and that is basically carried by the ductal cells which are lining them. Yes or no? So basically these epithelial cells which are lining, they are secreting certain mucus which is basically carrying these secretions. But because in case of cystic fibrosis, okay, this mucus is dehydrated, there is a defective mucociliary clearance, there is a precipitation of the mucus, and they become very hard and viscous. So they tend to block and they tend to plug all the ducts, and as a result the secretions, they cannot come outside, and as a result these secretions accumulate, giving rise to secondary infections. Ultimately there will be a lot of inflammation leading to atrophy of the gland with progressive fibrosis of that particular exocrine gland. So exocrine gland, okay, because of defective mucociliary clearance will lead to the plugging of the ducts, which is followed by atrophy of that particular gland and followed by progressive fibrosis. So what are the exocrine glands that we are going to see? For example, there is the pancreas, then there is your liver also. Okay, so there are different kinds of tracts that is there. Even in the intestine, okay, this problem is there. So the pancreatic abnormality, remember, it is one of the most common abnormalities to affect in cystic fibrosis, and it is very commonly seen in 85 to 90% of the patients. They are showing pancreatic abnormality. Now again, in mild cases, they will show accumulation of mucus in small ducts and some dilatation of the exocrine glands. The pancreas sufficient phenotype, we call it as the pancreas sufficient phenotype, and they show excellent growth and development. But in severe cases, which is presenting in older children and adolescents, the ducts are completely plugged. Okay, that causes blocking of the duct. There is subsequent infections, so there is more amount of inflammation, ultimately causing atrophy and progressive fibrosis. Now we all know that the pancreas is basically releasing certain enzymes like the pancreatic lipase, which is responsible for fat absorption. So if the pancreatic enzymes are not released, that is going to impair the fat absorption, not only the absorption of fat, but also the absorption of fat soluble vitamins like A, D, E, K, leading to avitaminosis A. and this avitaminosis is responsible for squamous metaplasia of the ducts. Plus, they are also impairing the intestinal absorption, stunting the development and growth of the child. Okay, so these are the morphology of the pancreas. Now, in all the cases, remember, the sweat ducts, they are morphologically unaffected. So, sweat ducts are the only exocrine glands, if you see, they are morphologically unaffected. They don't show any kind of destructive change. Okay, salivary glands will show same change, just like the pancreas. There will be progressive dilatation, squamous metaplasia, atrophy, fibrosis. Thick viscous mucus plugs, okay, in the small intestine of the infants, okay, can lead to small bowel obstruction, leading to what is called as meconium ileus. When the livers are involved, again the same pattern is there. There will be mucus plugging of the bile canaliculi, characterized by ductular portal proliferation and inflammation, followed initially by focal biliary cirrhosis, later by diffuse hepatic nodularity, which can be seen in up to 10% of the patients affected by cystic fibrosis. Now, the pulmonary changes, remember, they are the most serious complication, and in fact the most common cause of death in cystic fibrosis occurs because of recurrent cardiorespiratory problems. So, the viscid mucus secretions, okay, they cause secondary obstruction leading to infection of the air passage. Ultimately, they are causing lots of inflammation in the form of chronic bronchitis, bronchiectasis, and even lung abscess. So, there is an inflammatory destruction of the lung parenchyma. So, which are the most common organisms causing lung infection? Three most common. Number one is the Staph aureus, Haemophilus influenza, Pseudomonas aeruginosa. Now, the mucoid form or the alginate producing form of Pseudomonas aeruginosa is quite frequent and is responsible for chronic inflammation. Now, there is also an increase. Nowadays, we are seeing an increased frequency of another group of Pseudomonas species, that is Burkholderia cepacia. Okay, and they lead to what is called as cepacia syndrome, which is a fulminant illness causing increased mortality. Now, other opportunistic pathogens in the lungs include non-tubercular mycobacterial infection, aspergillosis, that is ABAPA, and S. maltophilia. Okay, S. maltophilia. Now, the fourth very important, not the fourth, okay, and lastly, if you see, azoospermia and infertility is affecting 95% of the males, okay. So, 95% of the adult males, they are infertile. So, 95% of the males suffering from cystic fibrosis are infertile, and they also have congenital bilateral absence of vas deferens. Now, let us now understand about the clinical features of cystic fibrosis, okay. So, we are now characterizing according to the glands which are involved. So, number one, we are going to read about the chronic sinopulmonary disease, which is characterized by persistent colonization or infection with typical cystic fibrosis pathogens, chronic cough and sputum production, persistent chest X-ray abnormalities like bronchiectasis, atelectasis, infiltrates, airway obstruction in the form of wheezing, nasal polyps, radiological abnormalities of the paranasal sinuses, as well as digital clubbing. So, these are the very important chronic, sinopulmonary disease. Now, the gastrointestinal and nutritional abnormalities. Now, in the intestine, in the infants, they can present with meconium ileus, distal intestinal obstruction syndrome, and rectal prolapse. Pancreatic, they can lead to pancreatic insufficiency, okay, recurrent acute pancreatitis, chronic pancreatitis, often sometimes even involving the endocrine part, leading to diabetes mellitus. Hepatic, they can lead to chronic hepatic disease, as we have already discussed, focal and then diffuse biliary cirrhosis, prolonged neonatal jaundice. Nutritional, there will be failure to thrive, acute malnutrition, hypoproteinemia, edema, complications which occurs because of fat soluble vitamin deficiency. Not only that, these patients also present with salt loss syndrome, that is acute salt depletion and chronic metabolic alkalosis. Male urogenital abnormalities, as I told you, there is obstructive azoospermia and there is congenital bilateral absence of vas deferens. Now, the most common cause of death in cystic fibrosis patients, okay, it occurs because of cardiorespiratory complications, very important, okay. It occurs because of persistent lung infections, obstructive lung disease, or right-sided heart failure, also called as cor pulmonale. Now, most common newborn screening test that is done for the detection of cystic fibrosis is to measure the blood levels of immunoreactive trypsinogen, okay, that is elevated in case of cystic fibrosis, okay, that is elevated in case of cystic fibrosis, that is the blood levels of immunoreactive trypsinogen. Now it can be equivocal or it can be negative in cases which are having milder CFTR mutation. In that situation, we are doing another screening test that is called as the nasal transepithelial potential difference. Now in cystic fibrosis patients, there is a significantly more negative baseline nasal potential difference as compared to the control. Now remember, whenever the screening test comes out to be positive, in that case we are going for genetic analysis of mutation. So we are going to carry out sequencing of the CFTR genes, and this sequencing of the CFTR genes for genetic mutations, it is the gold standard for diagnosis of cystic fibrosis. Now there are certain other tests also which we can do. One is your sweat test, which can show persistently elevated sweat electrolyte concentration. Now what is the diagnostic criteria for cystic fibrosis? Let us see. This is the last part of the lecture. So one or more of the phenotypic features should be there, or there is a history of the cystic fibrosis either in the sibling or parent or in the child, or there is a positive newborn screening test. Okay, so either of these three has to be present. Along with that, and number A, an increased sweat chloride concentration, or the sweat chloride concentration is in the intermediate range and there is presence of two disease causing CFTR mutation, or the sweat chloride concentration is in the intermediate range and demonstration of abnormal nasal potential difference or intestinal current measurement. Okay, so this is all about the cystic fibrosis. We have discussed everything in details. Thank you very much for watching this particular video.